So I'll be dealing with the surgical strategies in keratitis, Scalpel the savior. So oftentimes we'll be able to manage most of the keratitis on medical management, but we will have to convert it to a surgical therapy whenever it's required. So why do we need surgical treatment in case of keratitis? First would be a perforate keratitis. Whenever you get a perforated keratitis, you need to restore the integrity of the globe, and it needs to be performed as early as possible so that further damage can be prevented. And surgical strategies include glue BCL or Tennant's patch graft or penetrating keratoplasty. And sometimes you need to do keratoplasty to prevent further melt or to prevent endophthalmitis from happening. And it's an immediate eye saver measure in cases of keratitis. And the second indication would be a non-responsive or a poor response to medical management. Whenever you treat a keratitis, if you think that it is not responding adequately or it's progressing, then you need to convert it to a surgical therapy. So it halts the progression of infection despite maximal therapy, and it also prevents the eye from distorting. Like the anatomical success will be better, like preventing complications like secondary glaucoma, retinal detachment, choroidal detachments, and prevention of scarring also can be done with surgical management. So, as per the WHO definition, what is a non-healing microbial keratitis? Commonly, what we encounter is a bacterial and a fungal infection. In cases of bacterial keratitis, if it's not responding to your therapy, maximum medication or the adequate medication in 3 days, it's a non-healing ulcer in case of a bacterial keratitis. Whereas fungal, it's a slow-growing infection, so you have a little more time. Up to 1 week, you can wait if it's not responding to your treatment or the response is inadequate. It is called as a non-responsive fungal keratitis. So these are the plethora of surgical options available for a keratitis case. First would be an AC wash, which is a minimally invasive procedure. You are doing an AC wash with a fortified intracameral antibiotic or an antifungal, or you can add on an intrastromal injections in case of fungal keratitis. Next would be a glue and BCL therapy, where you are sealing the perforation. Along with that, you are adding some more antibacterial or antifungal effect in with glue. Third would be a Tennant's patch graft. And fourth would be a full thickness penetrating keratoplasty. And in cases of immune keratitis, you can go ahead with conjunctival resection or resection. And last would be a Gunderson flap, where the visual prognosis is very poor. You can go ahead with Gunderson flap to alleviate pain and halt the progression of infection. So first would be AC wash with intracameral or intrastromal antibiotic and antifungals. So any case which is not responding, you can go ahead with a AC wash. And intrastromal as well as intracameral in case of fungal keratitis, deep stromal infiltrates corneal endothelial plaques or large hypopyon, you can think about AC wash. And culture, and if you don't have a culture positivity on scraping, so you need a microbiological tissue, then again you can go ahead with AC wash. You can take out the hypopyon and aspirate it, and then you can send again for culture. You might get a better yield and you will be able to treat it better. So fortified intracameral antibiotics commonly used as per the sensitivity, but commonly you can use ceftazidime, vancomycin, amikacin. And in case of fungal keratitis, you can use voriconazole or amphotericin B based on the organism which you have suspected or what you have got in the culture sensitivity report. And you can always repeat the intracameral or the AC wash after 48 to 72 hours in any case of keratitis which is not responding to your medical management. So intracameral antibiotics, many people have tried. Intrastromal also people have tried, but intrastromally antibiotics are not given. These are some of the intrastromal evidences, but intrastromal antibiotics are not generally given because it causes edema, it causes endothelial cell loss. So intrastromal is given mostly in cases of fungal keratitis only. For bacterial, you are giving intracameral. In intrastromal, why you need an intrastromal injection? Because the antifungal penetration is very less compared to an antibiotic, fortified antibiotic. So you need some targeted, as in case of the TST protocol as mentioned here. You are targeting on the intrastromal tissue. So any deep stromal infiltrates not responding to your topical antifungals, or if there is recurrence after epithelial healing, there is poor drug penetration, especially the natamycin drop, which you use as a suspension. If there is no epithelial defect, it is not going to penetrate into the corneal stroma. In such a case, you might have to go ahead with a voriconazole injection or amphotericin injection intrastromally. So in this intrastromal injection, you have to take care that you don't inject into the normal tissue. You have to inject into normal tissue. You should not see it by injecting into the infected tissue and then again into the normal tissue. So these are the cases where you should go for a intracameral as well as intrastromal injections. And next is supportive therapy. In case of medical management, often we ignore this supportive therapy, like adding on antifungals or adding on anti-inflammatory. So these are the things. Anti-inflammatory drugs and anti-glaucoma medications can always prevent perforation. If the IOP is high, even if you give the maximal medication, there can be melt and perforation. So adequate either systemic or topical anti-glaucoma medications has to be given if the IOP is high, or if you think that the inflammation is high and is going to have a high IOP rise. Management of perforated ulcers is based on the size of the perforation. If the perforation is very small, micro perforation, you can just place a BCL if the chamber is formed, or if the perforation is less than 3 and the chamber is shallow, there is active leak, then you can go ahead with a cyanoacrylate glue application or a Tenon's patch graft. Whereas in large perforation more than 3 mm, you need either a lamellar patch graft or a Tenon's patch graft or a therapeutic penetrating keratoplasty. Cyanoacrylate glue, it's for the small perforation, as I said, but in case of moderate perforation like 3 to 5 mm, you can use some advanced techniques like a sandwich technique. You can take out normal epithelium from the normal tissue and place it over the perforation and apply glue over that. That is the epithelium drape technique. Or the eye drape which you get, you can take out a 3 or 4 mm of eye drape, place it over the perforation and then apply glue over that. Okay. And in case of descemetocele also, you can use glue BCL therapy, but it's not FDA approved. It's an off-label use. Again, it has an added advantage of tectonic support as well as antifungal and antibacterial effect, more in cases of antifungal. So butyl and octyl cyanoacrylate is commercially available. So it can be applied by plug. The iris tissue has to be released. The chamber has to be formed either with a air, or you have to form with a viscoelastic. And then with a 26 gauge needle or a small Sinski hook or something, you have to apply a very thin layer just to cover the perforation and apply it and keep it for drying. And then you can place a BCL over that. And usually it heals around 6 to 8 weeks. It disintegrates by itself and you don't have to remove it. But if it's not getting disintegrated, you can always attempt a removal of glue BCL, taking up the patient to OT. Not better not to do in the OPD, because you might have to reapply glue in the if it perforation reappears. Okay. And disadvantages of cyanoacrylate glue is it causes severe inflammation and vascularization. You need to cover up with a steroid drops. So this is a 16-year female patient with bacterial corneal ulcer perforated on maximal topical therapy. She was on cefazolin and tobramycin. So it has perforated, and I've done a glue BCL in this patient and it healed well. At the end of around 8 weeks, she was 6-9 parts. Even though there is a central scarring, the patient has a nasal clear area. She has a reasonable vision. Especially in a young patient, you can avoid therapeutic penetrating keratoplasty in such patients with a glue BCL. So this is another patient which has done very well with a glue BCL. Tenon's patch graft, if you're not confident with glue BCL or if your glue is not available, you can go ahead with Tenon's patch graft. Again, it's a biological tissue which you can take from the patient itself. The problem with Tenon's patch graft is you will have to suture, you will have to glue with a fibrin glue, you will have to place BCL. It can dislodge. That is one thing. The perforation sometimes might not seal with a Tenon's patch graft. You might have to add on cyanoacrylate glue also along with the Tenon's patch graft, and it causes severe vascularization. It's a tectonic tissue which causes an opacity. So central Tenon's patch graft, it's better you avoid it. Peripheral ones, always it's a good option compared to a glue BCL, because in cases of peripheral perforations, the glue dislodgement is more in cases of peripheral glue BCL compared to a central one. So if it's a peripheral one, Tenon's would be a preferred option compared to a glue BCL. So next is a lamella keratoplasty. There are multiple papers and evidence says that you can go ahead with lamella keratoplasty if it's progressing, but there is always a risk that interface infection and recurrence of infection with lamella keratoplasty. So not very commonly done, but if you think that you can manage with a DALC, you can do all that also if there is a cornea available at your center. So gold standard is for larger perforation, not responding to treatment, endophthalmitis, all these cases, you need to go ahead with a therapeutic penetrating keratoplasty only. So the goal is to clear 0.5 mm of clear cornea on either side of the infection, and you get a tissue for culture sensitivity so that you can add on post-operative antibiotic or antifungal or whichever medication you need to start post-operatively. You have to debride out all the necrotic tissue. You have to irrigate with antibiotic or antifungal if you have a culture in hand, or based on the clinical suspicion, you can give intracameral antibiotic or antifungal along with a therapeutic penetrating keratoplasty. So these are the various steps, and what are the things we should take care when you do a therapeutic penetrating keratoplasty. Always try to preserve the lens if it's clear, and whenever you are trying to take up a cataractous lens, don't you try to avoid expulsion. You try to avoid the posterior chamber, posterior capsular rupture, and if there is rupture, you have to do a limited vitrectomy only, and you have to try to maintain the anterior posterior chamber integrity. So this is one of the case with a Pseudomonas keratitis which was resistant to all the antibacterials, only responsive to peptides. This was a patient with 78-year-old male patient with glaucoma, progressive glaucoma on multiple anti-glaucoma medications. Post cataract surgery, 10 days had a surface infection. So initially he was started on amikacin thinking that it's a gram-negative infection, but the culture came out to be a multi-drug resistant Pseudomonas. We've added peptides, but it perforated in the very next day. So we did a peripheral patch graft, and the patient is doing well with that. Next, this is another case where the patient had progressed. We did not get any microbiological evidence. This has progressed even with treatment. And finally, we had to do a penetrating keratoplasty. So you can see that the sequelae of waiting for a penetrating keratoplasty in this case, there is a pupillary membrane, there is cataract, there is glaucoma. So you have to time your penetrating keratoplasty. Don't think that you can treat all patients with medical management. You have to go ahead with penetrating keratoplasty. If it's not responding to maximal medications, even in 3 days, 5 days, you have to go ahead with surgery. Otherwise, it will end up with these sequelae. So these are some of the penetrating keratoplasty cases. Post-operatively, you can add steroids after epithelial healing in cases of bacterial infections. Fungal, you need to wait for at least 2 weeks for resolution, and then only you need to add on steroids in cases of fungal keratitis after penetrating keratoplasty. So sequelae of penetrating keratoplasty would be a graft failure, cataract, glaucoma, and phthisis bulbi. So our role is to find out cases which can progress into these situations, and we need to prevent as early as possible. So outcomes of therapeutic penetrating keratoplasty, I'm not going to deal with all these things. So the survival rate would be around 78.4% at 1 year by Tan et al. So survival of graft factors would be host factor, donor factors, and others. Last resort, in cases of poor prognosis, you can go ahead with Gunderson flap. You dissect out the tenons from the superior conjunctiva. You layer it over the cornea and cover it, and it heals well. This is one of the case with Gunderson flap with a poor prognosis with end-stage glaucoma and keratitis, which we could do a Gunderson flap. Then in cases of immune keratitis, you can do conjunctival recession and resection to reduce the immune load. Amniotic membrane transplant, it has limited role, but in cases of infectious keratitis, once the epithelium is not healing, once the infection is under control, you can use it for control of the persistent epithelial defect, or if there is no biological tissue available, you can use it for closing the perforation. But the problem with amniotic membrane transplant is you will not be able to follow up the keratitis patient, you will not be able to assess the progression or recovery of keratitis if you put a AMG over the cornea. Last would be a tarsorrhaphy in cases of exposure keratitis with keratitis. Once you control the infection, you can always do a lateral or a paramedian tarsorrhaphy to prevent further recurrences of infection. So